So today's episode is very special. It's very special in a few ways. First, I have a very special guest who I will be introducing in a few. Uh, you guys will be happy to meet this distinct and exceptional guest that I have today. The second thing is that I'll be launching our YouTube page with this very podcast, which means you guys will see this special guest live, And with that said, let me introduce Dr. Gregory Ford, who is currently the Dean of College of Arts and Sciences at Fort Valley State University in Fort Valley, Georgia. Prior to joining Fort Valley State University, Dr. Greg served as an assistant professor of biology at Morehouse College and dean for the Division of Natural Science and Physical Education at Georgia Highlands College. Dr. Greg, it is an honor and my privilege to welcome you to our podcast today.
Thank you. It's a wonderful opportunity for me also. I see my primary job is sharing information, is educating people. So this is just another platform for me to hopefully inform people of what's going on in the world.
Thank you so much. And that's the core of our mission with this podcast, informing people about what is going on around the world. So having said that, let us start up, Dr. Greg. Can you briefly tell us, or just give us a little hint about the science of viruses and COVID-19?
Sure. So my background is as a scientist, so I have the opportunity now to speak as a scientist and as an administrator as we look to tackle this COVID-19 area. But in essence, a virus is a small germ, and it's a small germ that invades the body. And you've probably heard about viruses and bacteria, and many people ask me what's the difference, because you hear some drugs that fight bacteria and others that fight viruses. The biggest difference is a bacteria is a living cell. Something is living when outside of a host, or what we would call our body or the body of an animal, it can live on its own. A virus is not considered living. A virus is actually a little protein that has the DNA in, and the DNA is what makes us animals or plants, and we all have DNA. So these viruses have DNA, and they have to be inside of a host. And what they do is they attach to a cell, they put their information inside of the cell, and the cell begins to make their information or begins to replicate the virus and creates new viruses inside the cell. Well, once it does that so many times, it fills the cell up, and the cell literally bursts. And when it bursts, it releases all the new virus, and now these viruses go and attack other cells. So you can imagine for every one virus, every time it bursts, there's thousands of viruses that are affecting thousands of cells. So it's an exponential process. Viruses require a host, as I mentioned, and so a virus cannot live very long outside of a body. Another thing about viruses is they're specific to their host. So we've heard a lot about where did the virus come from, how did it get to humans? Well, an example I'm going to give is the bird flu. The bird flu was a strain of flu that only lived within birds, but viruses can change. So the virus happened to change to a form that adapted or evolved to affect humans. Once that happened, the virus came in contact with the human. The virus then chose the human as its host, and then it began to replicate in that human. Once it gets in one human, it can transmit all across to other humans and eventually across the world and become a pandemic. So COVID-19 is a strain of coronaviruses. So there's an entire family of coronaviruses. COVID-19 is a coronavirus that's specific to humans.
Thank you for providing that information and that drawing the distinction between bacteria and virus. And what strikes me most is the way and manner viruses replicate. And that brings me to the question, why does this particular coronavirus, COVID-19, why does it disproportionately affect minority population? Is it because of its ability to multiply and attack cells? And I don't know. You let me know, sir.
So that's a very interesting question that I've done some research on. And the first thing we think about are the health issues that minorities face. And I will touch on that, but I'm going to touch on first some things that we don't think about a lot. Prior to COVID-19, there was still a number of longstanding health inequities amongst minority and ethnic groups. And the difference is we have common experiences, and these common experiences are called social determinants of health.
Right.
So because we're in a specific racial or ethnic group, we have certain health determinants already that we know, but if health providers don't know those and don't understand those, they will try to diagnose us like they diagnose everyone else. But there are other things that we don't think about a lot that are actually underlying causes of the long-term damage associated with COVID. The first one being discrimination. And the first thought is how can discrimination affect the virus? Well, what you don't realize is if people are discriminated against, it can lead to chronic stress and even a PTSD. Chronic stress weakens your immune system. So by being discriminated against, it actually makes us sicker. Health utilization, and I'm not talking about access at this point, the fact that we're utilizing it. Minorities are more uninsured and underinsured. They also lack childcare. You have to have childcare to go to the doctor. You have to have childcare to miss a day of work to go to the doctor. Lack of transportation, especially in rural areas. You have to be able to get to your physician. Ability to take time off from work. There are many people that literally cannot take a day off from work or they'll lose their job. You can't afford to lose your job to go see a doctor. Communication and language barriers. And we're not just talking about people that speak other languages, but people that just speak and understand vocabulary differently than physicians and vice versa. So those barriers. And one of the biggest is distrust, that we don't go see the doctor because there's a lack of trust within in ethnic groups when they see physicians. Another thing is occupation. And I listened to the podcast you did with my dear friend, Dr. Harris, and she talked about occupational hazards. Right. Well, she talked about essential workers. Most minorities actually fall in categories of essential workers: grocery store workers, hospital workers, sanitation workers. So many of their occupation expose them to the public and at the same time limits their ability to work from home. Finally, there's the lack of education. The lack of education contributes to both the healthcare utilization and the occupation. And the last one would be housing, because minorities tend to live in larger households with more people. So by that way, because of crowding, there's more exposure. And also exacerbating this is the increase in unemployment and the increase in evictions. So all of these are non-health factors that increase the long-term effects of COVID-19 on minority and ethnic groups. But there are also a number, okay, you have a question?
No, go ahead, sir, go ahead.
But there are also a number of health-related things. We know within our community, we have things like type 2 diabetes, heart disease. We lead the nation in heart disease, high blood pressure, obesity, and a number of lung problems, including COPD and lung cancer. Because we're predisposed to these conditions, COVID-19 actually makes us sicker. And so being a cofactor, meaning having that and COVID, is many times what leads to death.
Right on. I'm so glad you brought up the point that non-health factors, which inversely are called social determinants of health, have a huge effect on the minority populations and COVID-19. And when you brought up the issue of chronic stress, you know, it struck home to me because I had an experience with that, you know, in my last job, you know, where because of the fact that I couldn't get, easily get permission to go see a doctor. Before I got the permission from my supervisor, I had to like pray over it and, you know, have thoughts all over my mind what's she gonna say. Is she gonna agree for me to go to see my doctor and things like that? So that struck home to me, you know, and I can see how other people, you know, especially the minority populations, can, you know, be affected by, you know, not getting permission from work to go visit a doctor, and how that can exacerbate, you know, their health situation. And, you know, when you put that side by side with COVID-19, you can see that they already have a disposing health issue, you know. Yeah, so thank you for bringing that up, Dr. Greg. You know.
Right, it's true. Things disproportionately affecting minorities and specifically African Americans aren't new. It's just that in the COVID-19 era, we're talking about it in COVID-19, and COVID-19 is one of those things that is bringing together the health and the non-health issues that face the country that are making ethnic minorities and specifically Blacks sicker.
Right. So having discussed that, let's talk a little bit about vaccine. You know, recently we heard in the news that Pfizer has, you know, they said their vaccine has 90% chances of, you know, being successful. We don't know what successful means because the entire data wasn't provided to us, but, you know, we are cautiously optimistic that the Pfizer vaccine will be rolled out at a time in 2021. So what is the real timeline of a vaccine, Dr. Greg?
Okay, so first I want to talk a little bit about Pfizer and their trial. Right. So what is a vaccine? So what a vaccine typically is they take an inactive or an actual dead form of the virus and they give it to you. Because the way your body works is when you're exposed to something, your immune city identifies it, it makes an antiviral to protect you from it, and in most cases, it's enough to isolate the virus and kill it. But some viruses like COVID-19, they replicate so fast, your body's immune system may not be able to keep up. So what they're doing is they basically have taken the virus, they've isolated the material, made an inactive or a dead form of the virus. And the first phase of the clinical trial is just safety. They give it to healthy people because what they don't want to do is give you an antivirus that's going to make you sicker. So there's easily past the phase 1 where they gave it to healthy people, and phase 2 where they gave it to a larger group, a larger population that was more diverse. This is, and you hear me say diverse, and I say that on purpose because this is why it was so important they had a diverse population to test the virus, because there are some things that work in specific populations that won't work in others. And so where they are now is they've given the virus to people that are healthy and exposed them to COVID-19. They gave it to people that have COVID-19, and then they gave what's called a placebo. And in many cases, they gave saline to people, and they're comparing the data between the two groups. What effective means in this case is either people that didn't have the virus didn't get the virus, or it means that people that have the virus, it helps them in recovery, so it should reduce the death. So the timeline, right now, they're looking to go to the FDA soon. The FDA is going to try to fast track approval, so it really could get approved before the end of the year. That's not the problem, the approval process. The issues are these, and I'll talk about them, but not in too much detail, but in production, in the doses, in the rationing, the distribution, storage, tracking, and scheduling. So what does that mean? First, they're already in production. What they did is they signed a contract with the government, and they're already mass producing. So the government has made a multi-billion-dollar investment, and they've already started stockpiling. But one thing we know about Pfizer's drug is that it has to be frozen. It has to be sub-zero. So it has to be in specialized refrigerators that can actually go as low as 180 degrees, negative 180 degrees. So it has to be stored really cold, which means anywhere it goes to has to have a similar type of refrigeration system. So that's one of the things that's happening right now. They're having to make sure that the different areas have the proper refrigeration, because if you ship it and don't have the proper refrigeration, then it's not going to be successful. So they are wrapping up production. So production right now isn't an issue. Doses. Pfizer's drug is unique in that it's a 2-dose drug. What has to happen is you have to get a dose. If you got a dose today, you have to get your next dose in 3 weeks. May not sound like a big deal, but if you think about it, number one, that means you have to get to your doctor appointment. Your doctor has to be able to see you within 3 to 4 weeks. Next, you have to work out your personal logistics of getting there. Next, we have to talk about rationing, because as they're making the doses, they can only send them to so many places, and there's still a timeline involved. So right now they're talking with FedEx. So if you think about it, if we get the doses ready by the end of the year, what else happens at the end of the year? The Christmas season. So while FedEx is trying to deliver your Christmas packages, they're trying to distribute a COVID-19 vaccine all over the world. So logistics, that's why I said the next thing would be distribution. So not only the rationing, but how do they get it everywhere? Then they have to set up a schedule where if I send it to Warner Robins, Georgia, now I have to send the next set to be there in 3 weeks because they have to get their second shot. But I also have to be sending sets in between to make sure new people are getting the shot. And the healthcare providers have to make sure that they track them, because if they don't have the shots available for the people that took the first shot to take the second shot, then the first shot's gonna fail. So now if you're really looking at it, those logistics aren't easy to maintain. They're actually building a system right now to manage it, because there's not a technological system powerful enough to manage that type of distribution worldwide. So those are the things we're going to be looking at right now. How will the companies manage the production? The military is actually going to be leading the effort in the distribution. And then how are the local health units and the local governments going to manage who gets what, when, where, and how, and in the process, how it's stored.
Wow. It's a complex process. And given all these complexities that you've mentioned, in addition to distrust, should people still submit themselves to the COVID-19 vaccine?
So I'm going to give a couple scenarios. So first, and I'm sorry, I'm going to back up because you did ask about the timeline. So here in my mind is the timeline. And of course, this is just my personal opinion based on what I've read. The first doses will probably go out, if it's approved. It has to be approved by FDA. If it's approved, the first doses will get out at the beginning of 2021. But those doses are going to go to military first, first responders, and other essential workers. They'll get the first round of vaccines. Well, what's been developed right now will be gone. We have a population in the world right now of about 7 billion people. And if you think about Pfizer's treatment being 2-dose, that's 14 billion units that have to be manufactured and shipped. So by the time it gets to where it's available to everyone, and then enough people are inoculated, because the goal is to create a situation where the virus has nowhere to go. The virus has to jump from person to person to live. In the one person, it can kill the one person, which of course one person is too many, but it has to go to different people to continue. If we inoculate enough people, the virus has nowhere to go. It's going to go to people that can fight off the virus. And what we hope is to reduce the viral numbers down to where they're manageable as they would be in a normal flu season. So that's our timeline. I'm thinking by the time we get to that point, it'll be early 2022.
All right.
So 2021 is going to be the time where we get the doses out, get it ramped up, get through a couple of seasons, and then 2022, hopefully things can level out. Wow. So who should take it? If you're high risk, you should take it. Why? Because the alternative is potential death. So who's high risk? Honestly, it's the same people that would be taking the flu shot. If you're taking your flu shot, take your COVID shot. So it would be Anyone that's immune compromised. So we're talking infants because their immune systems haven't developed, senior citizens because their immune systems aren't going to be as strong. And if you have any condition that affects your immune system, be it some of the ones we mentioned, HIV, or a number of other conditions that weaken your immune system, you should consider taking the COVID test. If you're not high risk, it doesn't mean don't take the test, but educate yourself. It's all about information. It's not about internet information. It's listening to things like this podcast. It's talking to your physician. It's talking to your networks. Hopefully by now people have built networks, but you have to make the decision that you feel is best for you and your family based on the current situation in your community.
Awesome. I hope people will listen to their networks and listen to public health experts and practitioners in healthcare who are giving them the honest information about this pandemic or this virus. Shifting base, Dr. Greg, can you talk to us a little bit about school reopening during this pandemic and the path forward?
So school reopenings was a very touchy area. It actually was changing on a day-by-day basis because there's a couple things we have to realize. Education is a business, number one, and it's not about making a profit for the institutions. Most institutions aren't profitable. It's about many of the communities that those schools are in are built around those institutions. So if those institutions aren't open, the grocery stores can't service the number of people they need to service. The small businesses won't have the foot traffic they need. And so then it starts to hurt the entire economy. It is a hard balance between economic and business, but what we had to consider was, can we afford to not open? And then it came beyond about the economics, about the students. Do students need colleges? And the answer is yes. College is more than just coming to a building to listen to an instructor. College is where you learn the things that you really need to be successful in your career. To be successful, you need those soft skills, you need those interactions, you need those networks. All of those are the type of things you build in college. College is where you grow into the person you're gonna be. So students needed the college experience. Our faculty and staff needed a paycheck. I mean, we're humans that have families to take care of. And so all those things had to be considered. And ultimately what was determined was we were gonna open, we were all going to open as safely as we could. We were gonna follow the government guidelines. We were gonna follow the science, not the politics, but the science. And we were gonna make decisions. And every institution had a task force that, whether it was daily or weekly or bi-weekly, met regularly to discuss what was going on at their institution. I'm proud of what Fort Valley State did in our response. As of today, we tested over 1,000 students. We've had less than 100 positive cases. And I'm sorry, we tested faculty, staff, and students. And in total today, we've had less than 100 cases. And of those cases, 20% were in the first 2 weeks of school, which meant the students had it before they came. And we didn't do anything beyond what the CDC said. We actually went and we marked all of our buildings to be one-way traffic. We socially distanced our classrooms. So what we did is we reduced the number of students that could be in a physical classroom, and we made an investment over $100,000 in technology to where we could do what's called blended synchronous learning. We had an instructor in the classroom, we had some students in the classroom, but the rest were working remotely, similar to what we're doing now, except it was fully interactive. So they were on a large board in the classroom, and the instructor could turn and see those students, and they could talk, they could raise their hand, they could ask questions. So we made it interactive. And that was the important part, to make sure students were involved. Every building had a PPE station that had hand sanitizer, that had wipes. So we did all the things the CDC asked, and it worked. There are institutions that didn't follow the guidelines as closely, and they have had to either move fully online or they've had to send students home. We were fortunate that our students followed the plan, as well as our faculty, staff, and the community followed the plan. The mayor of Fort Valley is actually an adjunct faculty. So we had regular communication. So the college and the community became one. And so that's what's going to really get us through this as institutions of higher learning, but really as communities, as we partner and we work together and make sure everybody's following the rules.
That is a huge investment that your university made, and I believe you guys are getting a return on the investment, because it's a huge investment that you guys are making. You know, taking the risk of having your students in class, and also curtailing the spread of COVID-19 within the community, because also you guys are following the CDC guidelines, that is listening to the experts, and that's what it takes, for us to, control this virus, as we speak. Dr. Greg, how are universities like yours and the university administrators, how are they navigating the business of higher education and the educational needs of students, and expectations of students and families, and the needs of the faculty and staff as well?
Right. So being a state institution, it wasn't easy, because the state of Georgia actually made cuts across the board. So every state agency had to cut budgets. So first thing we did is we froze hiring. So we didn't initially lay off anyone. We didn't have to cut jobs. We just didn't hire people. We had to ask a lot of people to step up. So we had to ask a lot of people to take on jobs that were not their job. In this environment, you're happy to have a job. So yes, you can pick up some other responsibilities. So we've managed our budget well. But the biggest thing, I think, is the second part of your question, is student need, because it does come down to customer service. That's one of the things I think that came out of COVID, because as we talked about institutions of higher learning being businesses, initially I think it was thought of as a bad thing. Right. But the penance of most business is customer service. If customer service is number one, then you're a good business. If our students are number one, then we are a good and viable business. So that's the reason we went to the blended synchronous learning format. It was the student's option. The student could decide if they wanted to come face-to-face or if they wanted to work virtually. We even gave them the option of, after they tried to do the online or the virtual or the face-to-face, they had the option to switch. So we had a number of students that initially said, I need to be in the classroom because I need to see my instructor. Once they saw the technology and tried it, they said, well, guess what? I can sit in the library where I feel more safe, or I can sit in my dorm where I feel more safe, and I still get to interact with my faculty. So we did fulfill the needs of the students. Before the semester started, we met with the student leadership. We met with the SGA and other student leaders. We did surveys and we asked them questions personally. We found out how they were feeling before they came on campus. After that, we met with them every week. So many of us on the administration have parts of the SGA that we meet with weekly that kind of gives us the climate of how students are. And social media has helped with that. We can watch and see what students are saying on social media, and we can ask them questions. I'm on social media with my students, so I can see their frustrations, or I can see what things they love, and I can, send them a message, say, hey, call me, let's talk about it. So communication is the key to this entire pandemic.
It is. A few hours ago, I was, discussing with my 12-year-old daughter. I was asking her, do you like online classes? She's like, nah, I don't. I don't, and the reasons she gave were not really personal to her. She was even thinking outside the box, thinking of other people, like people or kids whose parents don't have cannot afford internet connectivity, and kids who live in a very noisy environment and stuff like that. And I told her, but you are not experiencing all this. She was like, yeah, but those are my friends, so I'm glad that your school administration is actually taking the needs of the students very seriously and doing all you can to assuage their fears and support them during this pandemic. It is huge and it's personal to me. I appreciate you guys doing that, Dr. Craig. Yeah, go ahead.
I mean, it's personal to me because I'm a single father and I have 2 kids, and even to do this tonight, you know, I had to tell them, hey, I'm going to be in my kitchen area, so if y'all need to come in here, come in and be quiet, because my daughter took over my normal office because she was doing some paint projects. But I'm the parent, so I can easily say, don't come in here. But I have students, so students feel comfortable calling me. I've had students that said, me and my mother share a computer, and so she has some work due at her job, so I can't get on my computer. We've had students that had technology issues that we've assisted with getting some technology. So the institution bought some laptops that we were able to rent out. We bought webcams, but we were also fighting the fact that Dell was out of computers for a while, right, that the vendors for webcams were out because everybody was purchasing webcams. So we've been fighting for our students every step of the way. We have computer labs set up to where our students can still use computer labs that we've socially distanced. We literally went in and pulled off keyboards and mouses over the summer. Me and the provost were doing it in the library. So this is not, we were farming out. Me and the provost were doing this so that only every other computer could be used. So we try to be thoughtful because we are parents, and we're, you know, we understand the needs of the students because our kids are students with someone else.
All right. Thank you so much. Thank you, Dr. Craig. So tell me something about HBCU. You know, let me pretend for a minute that I don't know what HBCU is, but, you know, we have a large audience, you know, and they would like to know why HBCUs are growing in enrollment nationally.
So historically, an HBCU, which stands for Historically Black Colleges and Universities, were started post-Civil War to educate Blacks in the areas of teaching so that they can teach other Blacks and military services. So many of the institutions are well over 100 years old. Actually, Fort Valley State University is celebrating its 125th anniversary. But typically they were started by groups of Black and white men that worked together to understand that there was an educational need now that we were in the post-Civil War era. So they started specifically to educate Blacks. Over time, of course, with desegregation, Blacks have had the option to go to any school they want. We typically call predominantly white institutions, we term as PWIs. So you see a lot of Blacks go to HBCUs, but a lot go to PWIs. Those that are interested in athletics, of course, most of your D1 are PWI, so they want to do athletics there. Many still feel like they can get, I'm going to use air quotes, a better education of the PWI. Many feel like felt like they could get better opportunities. What has happened in the political climate as well as the health climate is students, what we're saying, are coming back home. So even though nationwide they're talking about schools seeing 10 and 20% decreases in enrollment, HBCUs are seeing increases in enrollment because I have parents that have called me in my office and have said, how are you going to keep my child safe? And when I lay out what we did, what we were doing at the time, because we hadn't done it yet, just for me giving the parent the plan, they said, I'm sending my child to Fort Valley State. And I'm a graduate of 2 HBCUs. I'm a graduate of Grambling State University and Meharry Medical College. I'm an active alumni with Grambling, so I know Grambling was the same way. Parents were calling saying, what are you going to do to protect my child? It's come back home. They see us as the nurturer that their children need, not only in this political climate, but again, in this health climate. You know, they hear about some of the larger schools and some of the issues they're having with whether it's a noose hanging from a tree or a sign being put up. They see those things happening, and those things contribute to something I mentioned earlier, which is the stress, the PTSD. Right. So they can come to an HBCU and feel safe that those things aren't going to happen. So our enrollments are growing because people are now realizing why HBCUs were founded, to give African-American students opportunities that they didn't always see at other institutions. And now we like to focus on the word historical because we're not only focused on Blacks anymore. We give all students opportunities. So HBCUs, even though historically they're Black, they're becoming more diverse. So we're seeing all populations, we're seeing international students. So But the difference is we still keep that same family mentality. A parent can call me as dean. They don't have to call these layers of people under me. A mother can call my phone number and have a conversation with the dean. You can't get that at many institutions. So that's why our enrollments are growing, because we give that nurturing that parents want their kids to have these days.
You can get that in most institutions in the world. I agree with you. Even for me, growing up in Nigeria, talking to our professors then in Nigeria was like talking to a god. Like, seriously, you can't even call your professor. But here is a different ball game, and which the HBCU is a family, just like you've described it, and that's why things are working out for you. I really applaud you and what you're doing for African Americans. Let's talk about social distancing. I was in college as well. I had friends who were social deviants, and we don't, when we were young, we not everything our teachers told us that we listened to. So how are students complying with this when they are in classrooms and dorms? That's one. And your school, do schools have people monitoring students, they're monitoring their compliance to these regulations as stipulated by the CDC?
Yes, so social distancing in college is tough. And I'll be honest, I thought in my institution it was going to be tougher than it was. The first thing we did, though, and it was actually pretty controversial when schools first started talking about it, is we changed our calendar into a 16-week straight calendar. We started a little early. We took out all of the vacations and all the breaks so we could end our calendar on the Wednesday before Thanksgiving. And by doing that, number one, students didn't get to leave. They stay on campus. They don't go on whatever trips they go on. But what they realize is now I'm out of school in November. I don't go back until January. I have 2 months to catch up on all that stuff. So that's number one, that we truncated the semester. And even in our spring semester, we're not going to start until the week after MLK. And we took out spring break and whatever other holidays were there. So our students would do 16 straight weeks, and then they'll be out for the summer. So our students will be out from November 27th till January 25th. Number two, our students learned over the summer that they do not want to be at home. Many of our students picked up a lot of responsibilities at home. And if you're the parent of an HBCU kid, don't tell I snitched on them. But many of them were saying, hey, I'm having to babysit my sibling. I had to get a part-time job. I had to give up my car. Please do not make me go home. So in return, our students have complied. I can honestly say we're about to go into week 15. There have been 2 students that I've had to address that didn't want to wear a mask out of our whole 2,700 population. When I walk through the campus, and I make sure I walk the campus every day so I see students and students see me. You see the students, if they're near each other, they have on their mask. They're not walking in the big groups you used to see them walking in anymore. They're following the rules because many of the students at HBCUs are still low income. They're still first generation. They don't want to be sent home. At school, they can see their friends. They don't have to do the additional work. They get 3 square meals a day. They see that as worth the sacrifice of following the rules. Where you see the issues are at the larger schools, and honestly, that doesn't have the same population. So they have students that aren't first generation. All of them aren't financial aid. Some are entitled. And because of that, they feel like they can break the rules. And so they do break the rules. And if they get sent home, their home situation is okay because they have their own room. They have a computer in their room. They can get in their car and go visit their friends. Our students don't have those same luxuries, and they understand that.
Wow, this is breathtaking, Dr. Greg. We have covered a lot today, and I want to thank you for coming to our show, and thank you for educating us on the science of viruses and bacteria, and also highlighting the fact that minority populations are disproportionately affected by this pandemic, and also by illustrating the importance of HBCU schools and what you guys have been doing to keep students safe and support them in their educational needs. And with that said, I would like to give you the opportunity to offer some concluding statements or remarks.
So I want to conclude on a positive note because there's a saying, you don't waste a good pandemic. Yeah. There are some things that have come out of this pandemic that are very positive. One, we as a country focus more on work than family. I think that this pandemic has switched that narrative when we focus more on family than work. It's also telling employers you don't have to micromanage your employees for your workforce to be productive. So people are able to work from home and you don't see profits declining because of that. So companies are able to keep going, and hopefully some of these things will continue. Me and my kids have gotten to spend more time together than we've ever spent because we're home more. We don't eat out as much, so we're eating better, which I talked earlier about health. So if you're home and not eating out as much and you're cooking at home more, not only are you using that family time that's going to reduce your stress, you're going to be healthier. So there are some really positive things that's going to come out of this pandemic once we come to the other side. And then when we talk about a pandemic, one death is always too many. I get that. But if you look at historical pandemics, typically death is around 20%. Right now, we still stay steady between 2 and 4%. So even though this virus travels fast and the exposure rate is very high, people aren't dying at the rates that they've died in other pandemics at this point. So we probably are better prepared for pandemics. Our bodies are better prepared for pandemics. Our young people are not dying from this pandemic. So those are all positives. And universities are going to stay open and keep our doors open because at the end of this pandemic, we still have to lead the world in innovation. So we have to be innovative. We have to develop the next generation of leaders, whether it's business leaders, political leaders, local leaders. We're going to be open. We're going to continue to develop the future generations of this country and of the world. So we are going to come through this pandemic. We're going to come through it. We're going to be resilient, and we're probably more resilient than before. So take those things and focus on those things that we're going to come out hopefully as a better people and as a better society.
Thank you, Dr. Greg, for coming to our show. I appreciate you. Thanks.
Thank you.